Good morning, all. Thank you very much for joining us today. Neurosurgeons by trade are somewhat forced into being morning people. So I think anyone who signs up for a seminar at 7 o'clock in the morning deserves extra credit. So thank you very much to all of you for joining us. And so move to the next. Right. Thank you. Yep. Today we're going to have a background on the Neuroscience Institute. I guess I would, and this is my perspective, I'm Paul Maurer. I'm the Chief of Neurosurgery for Rochester Regional Health Systems. A Neuroscience Institute is, all the phraseology is very important, but I guess my feeling that I just want to emphasize, we have outstanding facilities, we have outstanding equipment. Our technology, I think we can safely say, is truly state-of-the-art, whether it's buildings, a brand new multi-$100 million facility at Rochester General for neuro ICU and associated equipment, a brand new navigation computer system that's one of only 14 that was in the United States when we got it. So we do have all that side of what you envision as a neuroscience institute. That said, from my own perspective, whether it's an airline, whether it's a fire department, whether it's a store, it really comes down to the people that work in the building. The building doesn't provide the care. It allows the people to use the facility to provide the care. And so hopefully today, one of the things we want to showcase is some illustrative cases to demonstrate that, yes, we have the facility, we have the brick, the mortar, we have the technology. Anything we need, they've been very cooperative in providing to allow us to be at the cutting edge of where we need to be. That said, it's really the people that work in this system, in the Neuroscience Institute, the neurosurgery, neurology, rehab, all of the portfolio that makes up care for the patient from their first symptom to their last moment of being treated. It's the people that make the difference. And I think that we have a consortium of people in all the neurologic disciplines to provide very, very good care. We need to earn the patient referral, and I think we have the facility and the staff to do so. We're going to move through several cases that are meant to be illustrative cases. There should be learning points at each case for all of us. And at the same time, they're meant to show what the people in the system in this discipline can achieve, what using the equipment we have and the facilities we have to achieve these goals can be accomplished. And if you have questions along the way, let us know. And I think the questions that are going to go with the cases really are probably at a second or third year neurosurgery level in some instances. So if you get the cases, questions properly, I think we'll provide a year of free education for your children or something. But we'll move ahead through the cases and use them as illustrative points of what we try to do here at Rochester Regional Health Systems to provide state-of-the-art care in all the neurologic disciplines. We do have people and facilities for a vast array of neurologic, neurosurgical problems. I won't belabor this point by point, but virtually anything within the brain, spinal cord, and peripheral nervous system, it is our goal to properly and effectively care for those individuals. There's a wide variety of program assistance. I think the numbers, again, not to belabor this and get lost in the database, but numbers count. You know, if you're a pilot and you have 30,000 cockpit hours, that's different than 5,000 cockpit hours. So all things being equal, mileage does count in every field, in every discipline, in every job. Speaking for neurosurgery, because obviously that's my arena, the Rochester Regional Health System did over 2,000 major brain and spinal cord operations last year. Looking across the nation, we have intentionally kept the number of neurosurgeons at a very appropriate but not excessive number, so that each neurosurgeon has an extensive amount of volumetric technical experience, and those 2,000 operations of the brain and spinal cord are scattered across that horizon. There's over 100,000 therapy visits. The stroke center is very, very busy, one of the busiest in the entire region with over 3,000 admissions. As I said, the equipment really speaks for itself. We are not shy on equipment. In our own discipline in neurosurgery, we have a fairly amazing $700,000 computer-driven navigation system for brain and spinal cord that's actually manufactured in Canada, and one of the first ones based on non-radiation techniques, so the staff in the room isn't exposed, nor is the patient exposed to that. So we'll move on to the illustrative cases to go over what we've got to show. Any questions along the way, please let us know. So the first, Dr. Jay Morrow, who is a amazing expert in neurointerventional surgery, endovascular techniques for stroke, for all the things that encompass the vascular tree within the nervous system, will be presenting some cases, as will Dr. Christopher Kimmel, who is a neurosurgeon here at Rochester Regional Health, and they're going to present some clinical material to walk through some of the options we have, some of the things that we can do, both from an educational and an awareness standpoint. The first case is a 52-year-old male who presented to the emergency department with acute onset of headache, vomiting, confusion, and peripheral loss of vision. I would emphasize that in the world of the brain, the combination of headache, vomiting, and any change in mentation, because change in mentation comes in two forms. Loss of mentation, meaning lethargy or obtundation, and you can also have a qualitative change where you're fully awake, but the higher cortical functions, the orientation in space, speech, and so on can change. So we have both quantitative and qualitative changes in levels of consciousness, and this was a qualitative change. So we'll now walk through this case and learn some things from both its presentation and its treatment. The headache and vomiting combination in neurosurgery is a pretty big warning sign. That's like the oil light on your car for us. Once the pressure in the head goes up, the headache occurs, and once the vomiting occurs, it's a pretty good downhill slide.
Yeah, so I saw this gentleman first after he already undergone the imaging that you see up here. He's a relatively healthy gentleman, pretty high functioning. He actually owned a business, and among the spectrum of symptoms he'd been experiencing was he'd been having some difficulty doing calculations. He did have some peripheral vision loss on the right side, expected for what he had going on in this region, which you can see he's got a clear mass, probably best demonstrated on these images over here. Left side posteriorly, kind of in what we would call the parietal occipital region. It's distinct from the brain itself, so what we would call an extraaxial lesion, not within the brain itself, and clearly causing a considerable amount of mass effect. This is just some further imaging showing the lesion. It's pretty good size. I don't have the dimensions right in front of me. It's clear it's causing quite a bit of mass effect on the left hemisphere.
Yeah, the only other thing to add here is the mass does have some hemorrhage in the sequence on the far right. You can see these dark areas indicate hemorrhage within the mass, and there's some necrosis.
Yeah.
I think, I always emphasize to my patients in this setting, the best thing's never to see the doctor at all. Certainly the best thing's never to see the neurosurgeon at all. But thank God we live in a time where this lesion, a few decades ago would have been a death sentence. And for all of human history would have been a death sentence. And now, today, the question comes into, is this something that can be treated? And do we live in a time where it can be treated successfully? And that changes everything. It's an amazing progress that's occurred over 20, 30 years in neurosurgery.
So here's the first audience response. What's the most likely diagnosis? Well, we have a hyperdense mass on the non-contrast CT, avidly enhancing mass on the coronal T1 post-contrast imaging, and this just shows on the axial the contrast enhanced image. So I think they're going to pull up a response system that you can actually plug in. Okay.
Anybody who selects hemangiopericytoma and feels comfortable with that, if you could leave your resume with me at the end of the webinar, I'd appreciate it.
Sorry. So, there was some concern just based on, just go back to that previous slide. There was some concern this might have been something aggressive just based on some of the things that Jay already highlighted. So we did decide to get some more advanced imaging to look at the vascular supply to it, also with consideration that this is something, because of the size, this is basically a mass outside the brain that we're going to have to try to peel off an already swollen and angry brain. And if this is something that's firm and very vascular, that just makes for a long day and raises the potential for postoperative complications of hemorrhage or brain swelling. So for those reasons, we decided to get more advanced imaging with an angiogram. I don't know if you want to comment, Jay.
Well, they just flashed the results. It looked like most people had chosen glioblastoma.
Okay.
And it turns out, I mean, by imaging, I don't think it's definitive, but we would think meningioma first. You can kind of see here a classic dural tail type of a thing. It is extraaxial, which would not be a glioblastoma. So the fact that it's along the dura avidly enhancing, you'd lead with meningioma, but you may think about it angioperiocytoma.
I think the word extraaxial, for those of you that are not obviously in the neurology, neurosurgery world, when you have a mass in the brain, the question is it in the brain or is it outside the brain? Extraaxial just means outside brain pushing in, like an orange in a Jell-O mold. The Jell-O is its own mold, the orange is pushing in. Glioblastomas, just as an example, or abscesses tend to be in the brain itself. This looks to be outside brain pushing in, but any of these is possible. Okay, next slide.
Yeah, so Dr. Kimmel asked me to take a look at the blood supply, and the top two images are from an angiogram that was done the day prior to surgery. And frontal and lateral views from the angiogram, you can see an avidly enhancing mass correlating with what was seen in the left paracoccypital region. Supplied via middle cerebral artery branches here, some external carotid artery branches coming from below. This is the occipital artery. And then if we get more selective, the bottom two images on the left show our external carotid imaging, showing frontal and lateral views, those arterial supply enhancing the mass in the paracoccypital region. This is just the right side showing that there was some additional minimal supply from the right side at external carotid branches, but it was very minimal. And based on that imaging, it was determined that there was some safe supply to embolize with particles. So we used a microcatheter to navigate our way up from the groin in this particular case, parked it in one of the external carotid branches. This happened to be the middle meningeal artery. And you can see the mass is avidly enhancing from this location. Only seeing the mass, we embolize with very small particles. These are on the order of 100 to 300 micron particles. And this image is the microcatheter pulled back a little further. You can see that this was where the tumor supply predominantly was. There's a small amount left here. Additional particles were infused. And far right image shows that the middle meningeal supply was essentially obliterated. The bottom row shows the right occipital artery injection, the supply to the mass there from a couple of branches from the right occipital artery. These were then selectively embolized from this location and additionally from further distally within that branch. And at the end, the far right shows that the occipital artery supply was gone.
I enjoyed the phrase he used, park the catheter in the vessel, keeping in mind you're parking a microcatheter in the blood supply to your brain. So this is extraordinary. He makes it sound very pedestrian, but this is really very advanced, delicate work at which he does an amazing job, as evidenced here.
So I'll just go through this quickly. This is before and after embolization. The top row of images, the external carotid artery supply here, you can see is no longer present. You can see it on the lateral as well. This is before, after. And again, the overview, including the internal carotid artery supply, the before and the after, I would say at least 75% or so of the vascular supply was gone. A small amount of supply from a middle cerebral artery branch here.
Yeah, so the embolization was accomplished on one day, and then we took the patient to the operating room the next day, and it could not have gone more smoothly. I mean, the tumor had already undergone a pretty extensive amount of necrosis, and rather than it being kind of something firm that would, take a lot of time to debulk and, peel off the brain with trying to minimize the violence to the brain as you're doing that, the tumor basically sucked out. Case went very smoothly, minimal blood loss. Patient was doing great, walking around and eating by day one. I think he went home 2 or 3 days later. And he's since had follow-up imaging. He's gone, he's back at his neurologic baseline, running his business. And he's about a year out. He's had his follow-up MRI, which shows complete resection of the tumor, and underlying brain looks totally normal and healthy.
I think, again, just to move through the bullet list here quickly to get to the next case, using this wonderful accumulation of technology and very good people to make it happen, that's a very big tumor in a very bad place. I mean, that's Marlboro country in your brain. Posterior left hemisphere is not a good place to have a problem. And reducing the blood supply, it's not a matter of blood loss specifically. It's while you're rolling that off the cortex of the brain, because the part of the brain that thinks is like a wedding cake. It's the frosting that thinks. The inside of the cake, the inside of the brain doesn't think. It's thousands of wires and motor relays. But everything that you feel, you love, you hate, you talk, you read, you write is right under that tumor. And thanks to reducing the supply to allow Dr. Kimmel to roll this out with greater facility, it's a beautiful outcome from a very nicely performed team of actions. Very nice.
I was just going to add a few facts about the embolization itself. We typically use, like I said, smaller microparticles so we can penetrate deeply into the tumor. That helps with necrosis of the tumor. The substance some people have asked me about is polyvinyl alcohol. It's a polymer. I'm not really sure other than to know that it's a permanent embolic agent. And I think there are two camps, as far as surgical resection goes, some in the early time window and some a bit later. I guess I'm in this camp. I'm not sure.
Yeah, I am too. I mean, especially a tumor that size, I would not send a patient like that home with concern for necrosis and swelling of the tumor. Yeah. I think it worked very well, the timing that we had.
Yeah.
The tumor itself can have a stroke, if you will. The tumor dies if it's properly embolized, which it was, which means the tumor can then swell. So yeah, I'd be a little hesitant to let somebody walk with that having been done, although there is data to support both options. All right, next slide. Case number 2, 65-year-old female, worst headache of her life. As a person who's done a lot of brain aneurysms over the years, it doesn't have to be the worst headache. The classic headache for apoplectic hemorrhage in the brain, particularly from aneurysm, arteriovenous malformation, and other blood vessel anomalies. So we're talking about fairly young people here often. You don't see a lot of this prior to age 18 or 19. You do with vascular malformations, but the aneurysm world starts to brew up in the early 20s, and it's game on until the rest of your life. And so it doesn't, I don't generally encourage people to say, well, is this the worst headache you've ever had? Because we all know that pain's a very individual journey. So you'll get a lot of answers to that. It should be distinct and absolutely, people always remember the moment it happens. The hundreds of aneurysms I've done, I really can't think of anyone who had trouble defining when it began. Emergency department people, understandably, often say, I mean, my goodness, there's people in here every day with headache. But the key is the story. Everything in neurology, neurosurgery is the story. I frequently tell the residents we're training, 50% at least of the exam should be talking to the person, because we don't have little numbers to give. We don't have echoes like cardiology. You get these very objective numbers. The story. I was eating a piece of pizza. I took a bite and wow, I haven't had a headache like that in years. That's what we're looking for. Distinct, sudden, and severe. Nausea, just as with brain tumor, it isn't a required thing. Nuchal rigidity doesn't happen for 2 or 3 days as the blood bathes the meninges and causes the headache to go down the back of the spine and into the neck. But just the story alone buys you the workup. Really bad headache, my friend, very sudden. From that point on, that buys the CAT scan. And remember, these are bleeds frequently not in the brain, but around the brain. When an aneurysm ruptures, the blood goes around the brain, not in the brain. So by definition, if they're awake, they usually don't have much in the way of deficit. What they have is the story.
These images show the axial non-contrast CT, the subarachnoid hemorrhage in the region of the cerebellum on the left side. These are MR images, the T2 weighted. Bright areas show fluid and blood in this case. And you can see these extra dark spots. That's something to pay attention to. It's not a normal area for you to see these extra dark spots, which correlate with blood vessels. And the far right image is actually an MR angiogram. You can see these are the internal carotid arteries, your basilar artery here, and the bright area are too many vessels, basically.
So the issue now for me as a neurosurgeon is now you've hemorrhaged in the brain, but you're talking to me. Brain's working okay. So we have a lot to lose here because the territory is functioning, but what's the risk of this rehemorrhaging? And the death rate from a recurrent hemorrhage from an aneurysm is about 80%. About 20% of people re-rupture within the first 14 days. So at this point, the clock's ticking. And the most dangerous patient to care for isn't the comatose patient, because they're already moved down the conveyor belt to some degree. But the person that has the most to lose is the person who walked in the door. I've got a really bad headache today.
Okay, here's our second question. What's the most likely diagnosis here? I think we can start the response. Aneurysm, AVF, which is our arterial venous fistula, abnormal artery vein connection, AVM, abnormal tangle of vessels, tumor, or a combination of the two. And again, the CT just showing the hemorrhage here in the left cerebellar region, and the MRI showing these multiple dark flow voids indicating abnormal vasculature.
Next slide.
Very good.
A and
A and C. 62% of people answered A and C.
Wow. All right, I'm accepting resumes online at the end. So whenever there's a question of a hemorrhage around the brain or in the brain, the whole game at this point becomes what exactly is the cause of it, because that determines the likelihood you'll re-hemorrhage. Let's just say, for example, the person who put tumor for that can happen. Melanoma loves going to brain. Melanoma loves to bleed. Prostate never goes to the brain and doesn't bleed. So the minute you suspect this is tumor, the recurrent bleed rate, while it absolutely can occur, goes down, and you've got another problem you got to deal with. The tumor, where did it come from, blah, blah, blah. Lung bleeds a lot in the brain. Renal cell carcinoma loves brain and loves to bleed. But this is the more very curable, but very dangerous type of AVM and aneurysm combination. And so Dr. Morrow is going to go over the angiogram, and that's just our definitive, just like a coronary angiogram. Once we're like a hound dog, once we're on the trail of vascular abnormality, Dr. Morrow defines for us what type.
Okay, so here images from the angiogram. This is the AP and lateral view. We have the left vertebral artery, and you can see this compared to the right side over here, the left side, there's an abnormal tangle of vessels defined by that dark area in the left occipital region. Here you see it on the lateral, and based on this imaging, it was determined that preoperative embolization would be the course to take. And then on the images on the far right, this is an AP and lateral view, seeing our microcatheter in the left superior cerebellar artery. So it's actually this vessel here on the unmagged view. We're parked our microcatheter here. You can see it better defines the AVM nidus. And here you can see the causative agent for the hemorrhage, a very small perinatal aneurysm. So endovascularly, the primary goal initially is securing the source of the bleed, which is this, and anything extra you get is icing on the cake from this point. And here are magnified images of the AP and lateral, the microcatheter being very slowly advanced closer to the aneurysm. Here you can see it better, I think, on the lateral. Here's that aneurysm that we saw on that type right image, and the microcatheter is parked right next to it. from this location, we can safely inject some liquid embolic material, which I show on the next slides. And after that glue injection, this happened to be onyx that was used, which is a type of liquid embolic. You can see that that area is no longer dark. And this is just to give you a view, unsubtracted image showing the glue material here. This is a magnified view without the contrast showing our glue persisting in place. And you can see very faintly the aneurysm there that has filled with that liquid embolic agent. This is just to give you an idea of kind of the sizes that we're dealing with. This is the orbit here. You can see on the bottom here's the orbit, and this is our liquid embolic here. That's where we're working. And this image here just shows that there's decreased enhancement of the AVM nidus by taking out that superior cerebellar artery supply. And these images show the before and after embolization. Again, the AP and lateral views of the angiogram. And you see decreased enhancement of the AVM nidus, and you also see absence of that superior cerebellar artery supply to the AVM. And following this resection, I believe it was the day after that he was sent for resection of the AVM.
Yes, I took the patient to the operating room, I think about 24 hours later. Again, there's some legitimate discussion about when exactly to do it. Arteriovenous malformation, the nest you saw, that tangle of vessels, actually is there before the patient's mother even knows she's pregnant. It's a embryologic event. And that little tangle of vessels has high flow blood going through it every heartbeat, 80 times a minute, 60 minutes an hour, 24/7. And the bleed rate is, something on the order of, for the AVM, maybe 1%, 2% per year. It's just tick-tock, tick-tock. And some people get through their whole life. Some people, it happens at age 14. The most dangerous part of this case, which makes this a fairly unusual, fairly rare case, actually, from an epidemiologic standpoint, is the prenatal aneurysm in the posterior fossa. It's less than 5% of all AVMs. And the prenatal aneurysm carries about a 20% rebleed rate over the first 2 weeks. So Dr. Morrow did a fabulous job of taking care of the aneurysm, which then made my resection of the AVM much more straightforward. I took her to the operating room about 24 hours later. The picture on the left, you can see a hole in the back of the skull. I went up through the bottom of the skull in the subocciput. I exposed the cerebellum, dropped the cerebellum down. And with the operating microscope, I just worked my way around the AVM. If you look on the far right picture, or the two right pictures, you'll see just scout films that show aneurysm clips. Those are probably about 11 millimeters in size, a little less than half an inch. You can actually see a little trailer of Dr. Morrow's opacification of some of the vessels on that picture. I clipped the major residual feed supply to the AVM, rolled it out. And she had a very nice outcome, went home on day 3, I think day 3, top of morning, day 4. And she did extremely well. Again, a very nice progression of medicine, surgery, intervention throughout the world that's provided even when I started training, we could have tackled this, but it would have been a much more challenging case. And this whole thing took 2.5 hours, maybe top to bottom, and it was done.
Yeah, these images were just a follow-up actually about a month later after the resection, just confirming that the entire AVM was nicely resected. The far right images do show that as was seen on the CT scout images, there's a small amount of embolic material. You can remember that the nidal aneurysm was probably right about that location, and then the surgical clips here showing absence here of the any residual AVM.
Well, when I was in medical school, which was sometime after the Civil War, but not that long ago, I remember sometimes people would say, why in the world would you want to go into something that's so depressing? And 80% of my patients, whether it's brain or spine, are at least treatable. And the 2 cases we just looked at are total cures from certain death. So I think, frankly, neurosurgery is quite upbeat. So maybe I need a psychiatrist, but that's not in our portfolio here today. So we'll let that roll. But AVMs, as we discussed as I rolled through this, some of them present as a hemorrhage, some present as a seizure. the bleed rate for the aneurysm is higher than the AVM, and both of them add together to make this a pretty challenging situation for people. And the main key to this, what really saves a person like this, frankly, honestly, is the primary or the ER doc. We mop up the floor after everything got dropped, but it's the person in the emergency department that decides, yeah, this isn't just a headache, go home. It's the person in the primary office or the emergency department that actually, to be honest, saves the day for these people. It's the diagnosis that makes the difference. We'll take care of it, but if there's no diagnosis, it doesn't happen. And believe it or not, misdiagnosis in this around the world that's been substantiated in the literature many times is fairly high, actually. Next slide. Next slide. I think that, goes without saying, as we covered, the embolization makes an enormous difference in our ability to take care of these. Just like the tumor, it reduces blood loss, and it makes my working around her AVM was not substantially challenging, really, and much easier than I anticipated. Case number 3, 21-year-old female with significant weight gain, fairly rapid weight gain, hypertension in a young person, hyperglycemia, and as that constellation of symptoms, again, we perhaps to some degree deservedly get credit for taking care of these things, but it's the person on the front line in the primary office, in the pediatrician's office, in the emergency department that says, I don't know, you gained weight pretty rapidly, you've got high blood pressure at a young age, and you got an elevated glucose. I wonder if there's something more going on. That was the entry that allowed the cure. But without the entry, there wouldn't be a cure. So kudos to those people. This turned out to be an elevated ACTH, and I'll let Dr. Kimmel, who lives this world and does all our pituitary surgery, walk you through this.
Yeah, so just to kind of highlight that point that Paul made, it was an astute clinician this is a patient who kept presenting with necrotizing infections. And that's what kind of prompted the workup, found to have hyperglycemia and elevated cortisol. And that was what prompted the referral to an endocrinologist, who then sent the patient on to me. As most of you know, with pituitary disorders, typically when we're dealing with things involving the pituitary gland, it's either a hypersecretion event due to a hormonally active tumor, most typically an adenoma, or just general suppression of the entire pituitary axis as a result of mass effect caused by a larger lesion. Cushing's Cushing's disease caused by pituitary adenoma secreting ACTH causing elevated cortisol is typically a small entity. These are not very good quality images, and they're included to kind of illustrate the point that even for someone who looks at MRIs a lot like myself, this is a very unremarkable study. The radiologist commented that perhaps this area posteriorly, and I believe it was on the left, which is a little less intense, as we say, than the remainder of the gland, which normally lights up very brightly when you administer gadolinium enhancement because it doesn't have an intact blood-brain barrier. That was concerning for an adenoma, but because there's a little clinical uncertainty based on this, and if you really want to treat this patient surgically, you need to get a complete resection of the adenoma in order for them to achieve biochemical remission. And so in these types of situations, we do engage Dr. Morrow and our endovascular colleagues to do sampling, blood sampling. It's a complex procedure. I'll let Jay kind of talk a little bit more about it, but we need to basically find where in the bloodstream the elevated ACTH is coming from. And so he does a procedure called inferior petrosal sinus sampling.
So we'll let people answer this while I talk a little bit. Just curiosity, how many people out there know what vessel this arrow is pointing to? This comes from imaging that was done to help localize the source of the excess ACTH. And like Dr. Kimmel was suggesting on those prior images, what I noticed when I was seeing her in clinic is that although there was some question of an adenoma, I think it wasn't definitive based on that imaging. There was that hypointense area on the T1 post-contrast, but on the coronal view, it's kind of heterogeneous, both the left and the right. the T2 imaging, it's kind of heterogeneous throughout the pituitary gland here. You can see the optic chiasm here. And in the T1 area, again, it's heterogeneous signal intensity. So given that, it makes a great deal of sense, I think, to ensure, one, that you're operating on the right structure of the brain as opposed to the abdomen, and that you're treating the right potential source of the excess ACTH.
Yeah.
So it looks like most people were voting for inferior petrosal sinus, which I think is a great thought. And I kind of threw a little wrench in there with that question, because that would be what people should be thinking based on this picture. It's actually pointing to the cavernous sinus. So when we access this vessel to sample the venous blood there, the catheter is parked in the inferior petrosal sinus. We inject it. It refluxes across the cavernous sinus down to the contralateral inferior petrosal vein and internal jugular vein.
So this is a venous catheterization,
yes.
right? Yeah, as opposed
Thank
to, classically we do arterial, but this is a venous injection and a venous sampling. So this is kind of a complex procedure where we sample both peripheral blood as well as you do put two catheters, right?
Yeah, if you go to the next slide, I'll show
Okay.
the.
Okay, yeah.
So these were images, like Dr. Kimmel was suggesting, from the inferior petrosal sinus sampling. So the goal is here to localize central from peripheral. So we put a catheter in the right inferior petrosal sinus, and then on the left-hand images, a catheter in the left inferior petrosal sinus. And then over multiple time periods, we sample all at the same time, both inferior petrosal sinuses, and we have a catheter in the common femoral vein. So we get a peripheral sample, a central sample from both the left and right. We get all those samples at multiple time points, and then we give a medication to stimulate ACTH production. In this case, it was DDAVP, to help gauge which side, based on the chemistry analysis of those blood samples. And our endocrinology colleagues actually help us set up this whole process of sampling. They're there. It takes about 7 or 8 people in the room to get this whole procedure with, there's like 24 different blood samples. Then they help us analyze the data to help determine where the excess ACTH is coming from. And again, the primary goal is central versus peripheral. You want to make sure that you're operating on the brain for a good reason. And a bonus would be if you can say right versus left pituitary. The procedure is not without risk. We are near the brainstem there, so you can cause some brainstem ischemia, hemorrhage, 6 nerve palsy. The cranial nerves are in that location. And about 1 of every 1,200 people end up with some permanent neurologic deficit. And then there are the non-neurological complications, contrast reaction, groin hematoma. In particular to this patient population is DVT and PE because they are hypercoagulant.
So in this case, the petrosal sinus sampling was very informative. It did confirm central source of elevated ACTH, and it was a pretty clear distinction of the left side laterality versus the right, which was helpful for me in terms of directing when the patient went to surgery. So she underwent a kind of typical through the nose endonasal approach to the sphenoid and the sella. And I opened up the dura on the face of the sella and to the left and exposed a nice little, very distinct adenoma, which was removed in total. And the patient got a very nice biochemical remission. Normally, we look to see the patients actually become adrenally insufficient immediately after surgery because their normal gland has stopped making ACTH. And so there's not the normal biochemical drive to continue to produce cortisol. So her pre-op cortisol levels were in the 30s and 40s, and it dropped to like 0.5 on day 1. And many of these patients end up needing hydrocortisone replacement for the first few months after surgery. But she did get a nice biochemical remission. And last I've heard from the endocrinologist, she's lost over 100 pounds. So a nice clinical result. And the inferior petrosal sinus sampling was very key to confirming the diagnosis and guiding what we did at surgery.
Case 4, a 67-year-old male with visual issues. Next slide.
So where's the abnormality here? This is a 3D rendering of the MR angiogram of the blood vessels. And here's the axial MR angiogram. So the question for the audience is, where's the abnormality? The anterior cerebral artery, basilar artery, internal carotid artery, middle cerebral artery, or is there any abnormality? What abnormality? And this is your internal carotid artery here, so I'll make that a gimme.
The issue here is there an abnormality? Is it in any way related to visual disturbance? And if it is, or it isn't, what's the implication of, does this need to be treated at all? And if so, how? All right, enough time for the guests. Next slide.
So the just so people are aware, the internal carotid artery was the most selected. And the answer here is the anterior cerebral artery, which we'll show in the subsequent imaging. So based on the MR angiogram, the patient did go on to a conventional cerebral angiogram. Here's the AP and lateral views, and you can see this little balloon coming off the anterior cerebral artery here.
Because once you start looking, you sometimes today, the beauty of modern medicine is you find things. So obviously somebody with visual disturbance, you know, you're looking for occipital masses. In a younger person, you're maybe looking for demyelinating disease, blah, blah, blah. But during the course of events, you find things which then you determine the relative risk of this, which, as we alluded to earlier in the second case, this may have a real potential for problems down the road in the form of hemorrhage. And the death rate from an aneurysm rupture is about 25% in 24 hours, about 50% by the end of 14 days, and half the survivors are impaired. If it's treated in advance, prophylactically, I guess would be the word for an incidental finding. It's one of the very few things that we treat prophylactically. As they say, it's hard to make a patient who feels good feel better. But when you have something like this, it can harm you desperately.
Yeah, and that's exactly right. This was a total incidental finding. The patient's concern went from the visual problems to this incidental finding. This is just a mag view showing the aneurysm, and immediately adjacent to it, there's this little, what we call an infundibulum. There's actually a tiny vessel rising off that, so that's important to try not to injure. The bottom images show from the endovascular treatment, which the patient ended up choosing for management of the aneurysm. You can see our guide catheter here in the A1 segment, the microcatheter deploying the device, which is marked by these two dark areas. And here you can see that the device was actually detached. So it's actually, you can actually reposition it, withdraw if you don't like where it is positioned prior to detachment. And these two images show no complication after the detachment of the device, which in this case is an intrasaccular flow diverter. It's basically a mesh ball that will help the patient form its own seal along the bottom and clotting of the aneurysm. And these images are actually 6 months after treatment, showing that the aneurysm, you don't see any residual of it. It just really looks like a normal angiogram at this point. And this is that mag view. You can see the infundibulum with that tiny vessel coming off. As infundibulum is just a normal dilatation, and you can see the aneurysm's gone. When you look at the native imaging, you can see the two markers from the device, and the aneurysm is gone. And you know, the nice part is we're trying to get close to what is the gold standard in surgical clip reconstruction. And this gets close.
I'm probably going to dispute that slightly from the surgeon side. Do you have the other reconstruction?
Oh, yeah, the next slide.
Yeah, the next one.
Oh, yeah.
Now, if you look on the two colorful images on the right, having spent many years where this type of treatment that Dr. Morrow does, when endovascular treatment was not available for this, it would maybe be an analogy that's, I think, legitimate when bypass surgery existed, but there was no such thing as a stent. And everybody got a bypass because that was what you did. Got your chest cracked, got your bypass. Well, stents changed that. So similarly, for neurosurgery, this is something that for much of my career, early on, there were people were playing with it, but it was dangerous, wasn't all that effective. We opened every single head. We opened your forehead, you go under the frontal lobe of the brain, and then you work your way. Can you put a mouse to the bottom? Just put the mouse at the bottom of the aneurysm, at the top image. Okay, so right there. I opened the forehead. We published a whole series of, I think, 41 of these we did right under the frontal lobe through a window in the forehead. Results were very good, but you're getting your head opened. We're going under your frontal lobe. And we put one of the clips that you saw in the earlier case, case 2. We have these wonderful, very expensive titanium clips, and they go across the neck of the aneurysm and close it off so the blood can't get in, the aneurysm's cured. I'm actually going to tip my hat to Dr. Morrow, because many surgeons, my chairman always told me when I was training, it's good to be interested in one thing. Don't get too interested, because you can't keep an honest overview of the progress of medicine. Because if you make shoes or you do horseshoes, you want to do horseshoes. You're not interested in cars. And so as a surgeon, you have to be honest with yourself to be honest with the patient. So yeah, that's a cure. It is the gold, quote unquote, gold standard. But what Dr. Morrow does, and what he really, I think this is a beautiful illustrative case of what this man can do. He got rid of that aneurysm with, you don't open the head at all. And that's a cure. There are surgeons to this day, many, who cling with their fingernails in the wall saying, well, that can reopen. She needs another angiogram to make sure it stays closed. Well, that may be true, but having done a lot of these aneurysms open, if this was my wife, I'd have Dr. Morrow, and I would specifically have him do it. I would have him do this, because it's a 90% cure or better, and it's so close to clipping. If you so not a problem. You get another angiogram in a year, maybe CTA, whatever you're going to use to follow it up. And if it needed something else, you could always do something else endovascular, or if necessary, occasionally we clip. But 92% of all the aneurysms treated in Spain are now treated with endovascular technique. I don't look at that as a bad thing. It's like cardiac stents. If I need a bypass, I'll have one. But if you can treat it with a stent, I'm all about it. So I actually will say the gold standard is now probably both arenas can achieve it. And I'd certainly go for this method if it was my family, if it could be done. Dr. Morrow has very good objective overview, which is a key to his job and mine. And so if he can't rid you of this aneurysm with an endovascular technique, he calls me, and we clip those. But he's so good at this. My residents actually, in some ways, dislike him greatly because he eliminates an awful lot of surgeries by doing such a wonderful job with this. I think if this was my family, I'd be delighted. An aneurysm it's a weakening in the wall of the vessel. They're very rare, and I've done a few in people under 18 over the years, but it's pretty uncommon in the literature and in our own experience. Again, like I mentioned before, once you're age 20, 22, 23, it's game on. And the aneurysm prevalence, this is a variable number. If you go, I don't encourage Wikipedia, but if you go on things like that, you're going to see numbers 4%, 5%, because it's done from autopsies. And pathologists, of course, are the person who know everything a day too late. But that's a non-perfused brain when they do an autopsy. So those numbers actually may be at variance. The Mayo Clinic took 4,500 consecutive angiograms of the brain done for other reasons. They weren't looking for an aneurysm. In the old days, every tumor got an angiogram, for example. And actually about 1.5% of those brains had an aneurysm identified on angiography as an incidental feature. That actually means the rupture rate's much higher than was previously supposed, right? Because there's 28,000 hemorrhages from aneurysms a year in the United States. The supposition was, well, maybe 4% of the United States has an aneurysm. No, actually, probably about 1.5% have it. So the actual incidence of rupture is probably higher than was initially thought. And of course, the real issue here is this is walking on an 8-foot wide wall with an 8,000-foot drop. The likelihood you'll fall off isn't all that high per year, but if you do, it will be an unforgettable event. So if we find these incidentally and they're over 4 to 5 millimeters, the risk of rupture is real, and we recommend their treatment. If they're under that size, although there's a tendency in the literature and in the communities all over the country to call everything that's a bump an aneurysm. If it's under 4 millimeters, the risk is actually, according to the International Subarachnoid Hemorrhage Trial in Europe, which was a very good study, it's actually quite low if they're smaller than that, and some of those will follow. So if you send us patients and they have a 2 or 3 millimeter quote unquote aneurysm, we may well opt to follow that, but anything beyond that probably will get treated. Went through this. And I think that case, I think all these cases show, as I'm sitting here, listening to the cases they've done, I think we have everything that's needed to treat anything in the brain, spinal cord, or peripheral nervous system with a good degree of personal expertise and facility expertise. So let's move questions. Anybody has any questions? Please feel free to send them along.
We actually already have a couple.
Okay,
So,
questions.
The first question was asked from case number 1, the gentleman with the left occipital tumor, what the path was, and I did neglect to mention that. It was a very garden variety, the pathologist used the World Health Organization, WHO classification, so it was a WHO grade 1, which is the lowest grade, very benign, not atypical in any way meningioma, so that was the pathology on that one. And the second question is actually a very good question. Would there be a role for your services in the 6 patients who had brain-related side effects from the Johnson & Johnson COVID vaccine? So for those patients,
Great question.
yeah, who developed that unusual complication of low platelets with a hypercoagulable event, specifically cortical venous sinus thrombosis, we try as much as we can to treat those patients conservatively. Close observation, they typically need to be on blood thinners to avoid propagation of the clot. But in some unfortunate events, and I just saw a headline, one of these patients did end up having to have a number of procedures done. There are endovascular things that can be done. Jay can talk about that. And usually when things go very bad, that's when we get involved.
Yeah. The problem with that type of, every time your heart beats, 20% of the blood goes to your brain. That's how much blood your brain needs. Look at the size of your brain, look at the size of your body. But there's no heart to pump blood out of the brain, obviously. So everything goes by gravity through veins. It's called sinus thrombosis because the big veins that drain your brain are called venous sinuses. I would emphasize, those are not tubes like a standard vein. It's not like a garden hose. It's not like an artery. The veins that drain your brain are webbed sinuses. There's an endless series of labyrinthine web spaces that the clot accumulates to. And so passing catheters through is, you hit the web space, which then goes out the side of the vein, which now there's a hemorrhage there, so on and so forth. So the hallmark treatment for this kind of problem is anticoagulation, but the venous pressure in the brain is enormous because all the blood's going in the brain and it can't get out because of the clot. So the veins in the brain are unbelievably distended. They're almost arterial pressure. And so when you put them on heparin, unfortunately, some of these people, then the vein ruptures because of the pressure. Now they're on heparin with a ruptured vein. The hemorrhage gets bigger. Sometimes you take that out. That's always quite an event because of the venous pressure in the brain. This is actually a pretty dangerous condition.
Yeah, and I would say agree with that entirely. So for very select patients, I have removed clot from the superior sagittal sinus, the straight sinus, the transverse sinuses. Where I trained in Colorado, we actually saw a fair bit of this per year. Since moving here, I've not seen much of it at all, but especially in a younger person who is continuing to clinically deteriorate despite optimized medical and surgical management, ICP control plays a big role in patients' recovery from this. I have taken clot out. I've dripped TPA for a few days in the ICU, despite hemorrhage. You'd think that's contraindicated, but in that type of venous infarction hemorrhage that you get, a lytic is still a good therapeutic option. We're able to actually access the clot directly and drip a relatively low amount of lytic to help break that up. So I would say the short answer is, in very select cases, yes. Particularly, I've done it for young patients that are clinically deteriorating and potentially devastated by the disease. There's actually a high mortality left untreated.
This is a condition that, not to be arcane, but as they say, the best treatment for polio, don't get polio. This is one of those conditions. The best treatment for venous thrombosis of the brain is not to get it if it's avoidable, because it is the honest answer here. It's a very challenging condition to treat, and there's no magic. That's just the way it's worked over decades. And most of this that I've seen over the years was the combination of oral contraceptives and smoking. That's for us, that's usually where this comes from. But this is a new twist for a pretty bad problem in a small number of people.
Right. Small number of people, and the challenge is they're typically young, so they don't have atrophy. They have very full brains. And as I think Jay pointed out, it is a difficult balance between they're actively clotting, so you have to have them on anticoagulation, but because it's an issue of venous pressure, so it's almost like water backing up into your basement, that's what can happen, is that the veins become so engorged that they break through and there's bleeding into the brain. So it's a very challenging entity to treat. So typically we avoid making any incisions, but we do sometimes have to do things to modify or attenuate the increased intracranial pressure. There's a follow-up question, similar, asking about thoughts on the recommendation. There was a recent New England Journal of Medicine article about avoiding heparin in vaccine-related venous sinus thrombosis. And I think that that's probably, I mean, again, I'll defer to hematologists because that's really in their wheelhouse, but it makes sense because what we are seeing in some of these patients is a sort of very similar to people who get idiopathic thrombocytopenia. There is a dramatic drop in platelets, and it seems paradoxical that if platelets would drop, but that's because they're aggregating as some sort of a probably immune-mediated mechanism triggering these thrombotic and embolic events. So that probably makes sense. They probably need to be on a different agent like a bivalirudin or something like that, a non-heparin agent for their anticoagulation or direct thrombin inhibitor. Good question.
Well, I want to thank everyone for participating this morning. We know that it's a sacrifice to take an early morning hour of your time before you move on to your other things. So thank you very much. If you have any questions of any kind, please feel free to contact us in the neuroscience services, neurology, neurosurgery, interventional, rehab, everything else that makes this work for all of these patients. And again, thank you so much for your time.